Okay, sure.
Hello, everyone. Thank you for joining us at our first grand round here at the PUC. I'll present you in English and then Portuguese for the people who are don't speak as well, very well English. So Lauren Osborne is the first time I meet her is today, but she's the vice chair of clinical research and obstetrics and gynecology at Weill Cornell Medical College. She's been working with perinatal mood and anxiety disorders for a long time, I believe. She was previously at Johns Hopkins, and she leads a number of activities related to the dissemination of reproductive psychiatry in the United States. And it's a great pleasure to have her here to talk to us about neuroactive steroids in perinatal mood and anxiety disorders. Bom dia a todos, obrigado por participarem da apresentação de hoje. A gente está com a Lauren Osborne, que vai falar um pouco sobre esteroides neuroativos, né, em ansiedade e transtornos do humor no periparto. Ela estava antes na Johns Hopkins, ela coordenava um fellowship lá em psiquiatria reprodutiva, e agora ela se mudou recentemente para Cornell, e é um prazer tê-la aqui. Thank you very much for your accepting the invitation. Now I'm going to pass it to you so you can start.
Great. Well, thank you so much. It's really terrific to be here. Although, as I was saying before, I think next time I need to come in person. And I'm really pleased to be here to talk about one of my favorite research topics. I should say that I'm in an obstetrics and gynecology department, but I am actually a psychiatrist, and so my primary interest, both clinically and research, is in reproductive psychiatry. I don't have any conflicts of interest. I have some funding that I will acknowledge at the end of the presentation. And here's what I'm going to try to go over today. We're going to talk a little bit about what neuroactive steroids are and how they act on the GABA-A receptor, how they change across the peripartum, and a little bit about the menstrual cycle outside of pregnancy, how mood and anxiety symptoms are related to those fluctuating levels of neuroactive steroids at times of reproductive transition, and then a little bit at the end about how we got from the point of understanding their role in the body to the creation of synthetic neuroactive steroids that are used to treat psychiatric illness. So the first thing is to define some of our terms. What are neuroactive steroids? Well, they're molecules that are created either in the brain or in the periphery, but that act on the brain, and they're all derived from cholesterol. The ones that we particularly care about in reproductive psychiatry are the ones that come from progesterone. So progesterone, obviously one of the reproductive hormones that changes dramatically across pregnancy and the postpartum. And the molecules that we think act on the brain and have a relationship to perinatal mood and anxiety symptoms are the ones that come from this progesterone metabolic pathway through allopregnanolone. And there are some others that aren't pictured in this page that I'll introduce you to as we go along. And the reason we care about these neuroactive steroids and want to study them in reproductive psychiatry is that they act on the GABA-A receptor. The GABA being, of course, the most important inhibitory neurotransmitter in the brain, and the GABA-A receptor also being the place that a number of other inhibitory molecules act in the brain. So this is the receptor that alcohol acts on. It's also the receptor that benzodiazepines hit, and it's the receptor that neuroactive steroids hit, and they all hit in different places, as you can see. So neuroactive steroids are allosteric modulators of this receptor. They don't attach to the same place that GABA does. They attach to a different structure. And I want you to just notice that this conformation of the GABA receptor, it's this pentameric unit composed of these 5 different subunits. And what we're showing here is its conformation, not in pregnancy, where you see 2 alpha units, 2 beta units, and a gamma. That changes dramatically across pregnancy, and that has something to do with the relationship of mood and anxiety symptoms with neuroactive steroids. So how do these neuroactive steroids work on the brain, and how are they related to mood and anxiety symptoms? Well, not talking about pregnancy now, but just in general, if you have a stressful event, your stressful event actually causes GABA itself to go down within the brain. So you're not having as much GABA to buffer that stressful event, and that causes anxiety to go up. When anxiety goes up, that's when the inhibitory neuroactive steroids kick in to buffer that problem of GABA being down and anxiety being up. When the inhibitory neuroactive steroids kick in, they attach to that GABA A receptor, they enhance GABAergic tone within the brain, and that causes your anxiety to come down. So that's the way it's supposed to work within the sort of normal healthy body. But we know that in people who have chronic mental illness, those inhibitory neuroactive steroid levels are lower. So if you look at somebody who has chronic major depressive disorder, you measure their allopregnanolone, the most commonly talked about neuroactive steroid, you measure that in major depressive disorder, you're going to find lower levels than you do in people who don't have major depressive disorder. And we know that when you give an SSRI, you actually reverse that. So SSRIs are thought to act, we think that the role is mostly through acting on the serotonin system, but they also act on the GABA system. And so that seems like a relatively straightforward path, right? Oh, the inhibitory neuroactive steroids are down, we can give SSRIs to reverse, but that isn't the way it works with regard to reproductive transitions. It's much more complicated. So I mentioned before that they're down in major depressive disorder, but premenstrual dysphoric disorder, it's a totally different pattern, right? And so what we see here is allopregnanolone levels across the menstrual cycle and their relationship to irritability scores. And so what we see here as the allopregnanolone, we go across the menstrual cycle, this is ovulation. Then in the luteal phase of the menstrual cycle, allopregnanolone levels rise steeply and then fall steeply. And what happens with symptoms, that irritability that's such the hallmark of PMDD, it rises as allopregnanolone rises and then falls at menstruation. So here we have a state in which as allopregnanolone is getting higher, mood symptoms are also getting higher. So that's the opposite of what we said with major depression, right? And in fact, there's some people who speculate that there's an inverted U-shaped curve for premenstrual dysphoric disorder, where the people who do not have premenstrual dysphoric disorder have these luteal phase physiological levels of allopregnanolone that is a kind of sweet spot in the luteal phase, whereas people whose allopregnanolone levels are either too low or too high may be the ones that are experiencing mood symptoms. So a very different picture from what we see in major depressive disorder. So the question is then, what about pregnancy? If we know that there are these shifts across the menstrual cycle and the pattern in PMDD is so different from MDD, what's it like in pregnancy and postpartum, and how is that related to mood and anxiety symptoms? Well, this is what the whole neuroactive steroid pathway looks like. And you can see it's very complicated. The ones in yellow are the ones that are inhibitory neuroactive steroids. The ones in blue are actually excitatory, so they're going to have the opposite effect. They don't have a calming effect on the brain. And we have a little bit of data on many of these neuroactive steroids, but as you can see here, it's kind of all over the place. So some data shows that neuroactive steroid levels are related to mood and anxiety symptoms in the peripartum. Some evidence shows that they aren't. So a really mixed picture. And we're going to focus in from here on allopregnanolone, because that's the one that's been studied the most. We know that it's an allosteric modulator. It's an inhibitory neuroactive steroid. And that's where the bulk of the research has been done in pregnancy and postpartum. So what do we know about allopregnanolone? It's involved in the regulation of emotions. It's an anxiolytic molecule. It also has actions on myelination and regulation of the HPA axis, and also regulation of inflammation. So what I'm presenting today is all going to be related to allopregnanolone and neuroactive steroid pathway, but we have to remember that all these other things kick in, right? That when allopregnanolone is active in the body and is having certain effects, we also have to take into account the effects of the HPA axis and the effects of the immune system. So it's never in a vacuum. So what happens to allopregnanolone in normal, healthy pregnancy? So across the course of pregnancy, the levels will rise 7 to 9 times. And that makes sense, right? We know that progesterone rises across pregnancy. Allopregnanolone rises along with it. And as those levels rise, the expression of the subunit that binds allopregnanolone goes down, the subunit of the GABA A receptor. And that makes sense, right? Because if you're flooding the brain with allopregnanolone, remember this is an inhibitory molecule. It makes you calm, makes you a little sedated. Think about taking a lot of benzos or having a lot of alcohol, you're going to feel calm and sedated. If the body didn't respond by changing the way the receptor is expressed, that you would be comatose all through pregnancy. So you can't be. So the receptor has to change. And so the binding capacity of the receptor and the expression of the subunit that binds to allopregnanolone goes down across pregnancy. So we saw in that previous slide where you saw the pentameric subunits, that it's that gamma subunit that binds allo, and across pregnancy, the expression of that gamma subunit goes way down, and the expression of another subunit, the delta subunit, goes way up. We know, however, that in normal pregnancy, within 48 hours after delivery, everything rebounds. The receptor goes back to its normal level of expression. It's not downregulated anymore. It starts that within 48 hours, and by 6 weeks postpartum, it's completely back to pre-pregnancy levels. And that makes sense, right? Because you're not flooding the brain with allo. The progesterone and estrogen go down over 100-fold within 24 hours of giving birth. So you have to suddenly adjust the system. And one of the ways that we know that the body prepares for that is that the ratio of allopregnanolone to its precursors may drop before delivery, thus sort of sending a signal to the GABA receptor, you need to start upregulating again because those levels of allopregnanolone are going down. So this is from a study a few years ago that charted the relationship of the ratio of allopregnanolone to 5-alpha DHP, which is the immediate precursor in that pathway from progesterone. And you can see that it's rising and rising across pregnancy, but then at the end of pregnancy, it's suddenly dropping. So again, giving that signal to the GABA A receptor that we need to get ready to upregulate after birth. So what does this mean in terms of allopregnanolone levels and mood and anxiety symptoms? So I've showed you what it's supposed to be doing across pregnancy. Is it behaving differently in people who have mood and anxiety symptoms? And the answer, as it was with looking at all those other neuroactive steroids, is a mixed picture. So these are just a few of the papers that have been done that have looked specifically cross-sectionally at allopregnanolone levels and mood and anxiety symptoms at various time points in pregnancy. And it's very mixed. Some of them have found that lower allopregnanolone is associated with concurrent depressive symptoms. Some of them have not had that finding. We don't have any that have showed that it's higher, but we have some showing that lower is associated with concurrent symptoms. And we don't really know that that's a consistent finding, though. There's a paper that came out a couple of years ago that advanced the field by examining not just allopregnanolone, but multiple neuroactive steroids across pregnancy and postpartum. So not just looking cross-sectionally, but longitudinally. And so that was a big advance on some of the previous research, but it had a definition of perinatal mood and anxiety that was perhaps not related, not the best way to look at it. So in other words, it looked at a mean of the neuroactive steroid levels across time, and it combined people who had depression and people who were at risk for depression. So you didn't have a sense of what is the allopregnanolone level at a certain point in time, and how is that related to the timing of the rising of the illness. So there is depression and anxiety that can arise during pregnancy, and that's biologically probably different from depression and anxiety that arise in that immediate postpartum period, which is more likely to be related to that cliff that we go over in terms of hormones at childbirth. So again, this paper advanced the field, but still we couldn't tell what was going on in terms of timing. Why is it the allopregnanolone levels that are causing these mood and anxiety symptoms? Are they a response to it? Is it concurrent? Is it predictive? We didn't know. We also have evidence that there may be a genetic contribution. So there's been research into AKR1C2, which is a polymorphism. It's the gene that regulates the metabolism of progesterone down to allopregnanolone. And there's evidence that people who have a polymorphism in that gene will have lower levels of allopregnanolone. So could that be something that's related to the development of mood and anxiety symptoms. Well, this study from Ingrid Sundström-Poroma's group in Sweden found that people who had this, this particular polymorphism had a steeper rise in depressive symptoms across pregnancy. So if they had the polymorphism that was associated with lower levels of allopregnanolone, they were more likely to get more sick across pregnancy. We also have to remember the action of the receptor, right? Because we're talking about levels of neuroactive steroids, and we know that they act on the receptor. But remember that allopregnanolone and those inhibitory neuroactive steroids are not arising in a vacuum. They're part of this metabolic pathway from progesterone. And when we get down to the end of the metabolic pathway to allopregnanolone, that's an allosteric modulator of the GABA A receptor. So it has inhibitory actions on the brain. It's calming, it's sedating. But its immediate precursor is actually an inhibitor of GABA. So an inhibitor of an inhibitor has the opposite effect. It's excitatory. So if you mess with this pathway from progesterone down to allopregnanolone, not only are you affecting how much of that inhibitory molecule exists, but you may be favoring the production of a molecule that has the opposite effect. We also have to think about the receptor itself and how that has an effect on the levels of allo. They both affect each other. And there was a study a few years ago that knocked out the GABA A receptor in mice and looked at whether that had an effect on mood and anxiety symptoms. And they compared virgin mice to mice who were postpartum. And you can see if you knock out the GABA A receptor in virgin mice, it doesn't seem to make a big difference. There must be, some way that the mouse compensates. It's not really related to this increased anxiety and mood symptoms. But if you knock it out in a postpartum mouse, you can see that it has a dramatic effect with these. The black is the knockout mice having increased depressive-like symptoms. I mean, it's a mouse, it's not depression, but depressive-like symptoms in the mouse when they're in that postpartum period. So there's something unique about the postpartum.
Is this the study where they did not the knockout of the delta subunit of GABA A receptor?
Yes, exactly.
That the mice cannibalize their children with is that the one that the horrible result? Yeah. No, good results scientifically, but they use a lot of mice models to study that.
Yeah,
and there's a doubt.
It's dramatic.
Yeah.
Yeah.
Okay, sorry to interrupt.
Yeah, no worries at all. Interrupt anytime. So I'm now going to walk you through the data that's been produced by our lab regarding this, because what I said before was that we have a lot of data that shows these cross-sectional relationships, and we have some longitudinal data, but it isn't specific in terms of the timing of what arises when. And so that's something that our lab has been trying to clarify. And I'm going to show you the results of 3 different studies. So the first one was a study where the PI was my colleague and mentor, Jennifer Payne. And she studied 62 women, all of whom had a diagnosis of a mood disorder. So they came into pregnancy already diagnosed with a mood disorder. Most of them, it was major depressive disorder. A few had bipolar disorder. And they were followed prospectively through pregnancy and up to 3 months postpartum. They were treated as usual, including medications. They were managed by their clinical psychiatrist. We didn't change anything there. And they came in for scales at a clinician interview and a blood draw at up to 6 times across the pregnancy and postpartum, up to just depending on when they enrolled. Some enrolled first trimester, some enrolled second or third trimester. And this is what the population looked like. And I bring this up because it's something that we're trying to change. And actually, my moving to a new institution, I think will change that, in that a lot of the people who participate in research, at least in the United States, are wealthy white women. And so this population was an older population. It was largely people who were married or otherwise partnered, very heavily educated. We have a lot of, this was at Johns Hopkins, a lot of people who are doctors or graduate degree people participated in it. And, and it had, I guess I didn't put the ethnicity and race on this, but it was a largely white population. And about half of these people became ill with postpartum depression in the course of the study. So they were all being treated by their regular clinician, but half of them became ill anyway. And what did we find when we looked at allopregnanolone levels? Well, we found a really strong relationship between allopregnanolone levels in the second trimester and the development of subsequent postpartum depression. So the levels weren't related to concurrent symptoms of depression. These women were healthy during pregnancy. They were euthymic during pregnancy. But every additional nanogram per milliliter of aloe that they had in the second trimester had a protective effect, and it reduced the odds of developing postpartum depression by about 63% for every additional nanogram per milliliter. And what you're seeing here is the curve of the odds of developing postpartum depression as allopregnanolone goes up. So you can see it's a very strong effect, but it doesn't make sense that it's not an immediate effect, right? It's aloe in the second trimester. So it's not telling us that something about the aloe in that moment buffering depressive symptoms. It's something in there's a chain that goes from that aloe in the second trimester to the development of postpartum depression. And so we've been working now on trying to figure out what that chain is. So the next study we did was about 300 women. These women were half people with mood or anxiety disorders and half people who were healthy controls. Again, we followed them prospectively through pregnancy and up to 6 months postpartum. Same study design. They were being treated. Some of them were taking medications, which of course can affect allopregnanolone levels. And we did the same kind of structure where they came in up to 6 times across pregnancy and postpartum. We have only a subset of those women had allopregnanolone levels drawn and had enough data at all 3 time points. So the data I'm showing you are from 124 people who had both allopregnanolone levels and all of their mood and anxiety symptom scales at second and third trimester and 6 weeks postpartum. We included as covariates sleep, age, and the visit timing. So did they come in at the time they were supposed to, that second trimester visit, or was it off in some way? And we included them if they had their blood draw and the psychiatric scales at least once and no missing covariates. Again, you can see, just as with the other group, this is a very highly white and highly educated and highly married group of people. So not very representative. And what did we find this time? Well, this time we found almost exactly the same relationship that we found last time. So that these graphs are showing you the total score on mood and anxiety scales at 6 weeks postpartum and the relationship to allopregnanolone in the second trimester. And you can see that it's a different type of graph, but we're seeing exactly that same relationship, right? As the EPDS scores are higher in the postpartum, that aloe is lower in the second trimester. So the lower aloe in the second trimester is predicting postpartum development of mood and anxiety symptoms. This one is showing you the Edinburgh Postnatal Depression Scale. This is the state of the Spielberg State Trait Anxiety Inventory, and this is a perinatal specific anxiety inventory. And you can see, although there are different levels of steepness and different levels of statistical significance, but the pattern is the same across all 3, that negative slope. So the difference between this and the other population, though, was that we had healthy controls here. So we had people who did not have any history of a mood or anxiety disorder. One thing we found was that sleep was a really strong, significant, and independent predictor. So that's why we had to control for sleep in all of these studies. But then we also wanted to say, well, is this pattern different for the people who had a prior history of a mood disorder and the people who didn't? We're seeing that strong negative line for everybody, but half of these people were healthy controls. And so we split the group up into people who had a prior history of a mood disorder and people who did not. And we saw an interesting pattern when we did that, which was that strong negative slope that we were seeing, the relationship between postpartum mood symptoms and second trimester aloe, seems to be driven by the people who did have a prior history of a mood disorder. So that's the people in blue here. And so you're seeing, again, across all 3, the depression scale and the 2 different anxiety scales, we see that negative slope for the people with a prior history of a mood disorder. We do not see that for the people who do not have a history of a mood disorder. In fact, we see the opposite, a slope in the opposite direction for the people without a history of a mood disorder. The other thing to notice that's very different from the previous study is that the previous study, about half of the women met criteria for an episode of postpartum depression. So they became quite ill in the postpartum. In this study, people didn't become ill. You can see that our top EPDS score is 16. Now 13 and above is considered consistent with an episode of major depression, and the vast majority of our scores are well below that. So very few people would have met criteria for an episode of postpartum depression. This was a healthier population. Half of them were healthy controls. The half who had a history of mood disorder, evidently they were getting better treatment this time than the previous time. So So we then decided to say, okay, we have this same kind of relationship that predicts the development of postpartum symptoms in people who, according to allo level in the second trimester. But this time we also decided to look concurrently. So what does it look like if you look at the relationship between allopregnanolone and concurrent symptoms? And this, I'm just showing you only depression. And it's an interesting pattern. So what we're seeing, if we look at current EPDS scores and allopregnanolone at the same moment, in the second trimester, we see again that negative slope. So the lower your allo is, the higher your EPDS score is in the second trimester. Third trimester, there's no relationship at all. And in the postpartum, we're having the opposite relationship. So we're seeing a U-shaped curve across the perinatal period, which indicates that what the effect we're seeing can't simply be an effect of higher allo is good and lower allo is bad, because we're seeing that relationship change across the peripartum. And that very likely has to do, again, with the changing of the receptor, right? If you have high allo in the peripartum, in the postpartum, and you've already upregulated your receptors to get back to that non-pregnancy state, and your allopregnanolone is high, well, maybe that's a situation that's more like PMDD, where we saw those high levels of allopregnanolone related to high irritability scores. So because the receptor conformation changes, the relationship of the allopregnanolone to the mood and anxiety symptoms also changes. So what can we conclude from those two studies? Well, we conclude that low allopregnanolone in the second trimester predicted anxiety, I just read anxiety, but anxiety and mood symptoms in the postpartum. And that relationship was really driven by those who had mood disorder histories. It was not driven by the people who were healthy. We controlled all of those studies, by the way, for the people who used medications. I mentioned that we allowed people to be on medications, and there's a concern that that would really change these results, because remember what I said at the beginning, that SSRIs increase levels of neuroactive steroids. So that might change our results. In this case, it did not change our results in either study. The first study that I showed you, we had a high number of people on medications. I think about 75% of those people were using medications at some point. The second study was a much smaller percentage of people on medication because we had those healthy controls, but in neither case did medication use change the results. We did notice that sleep was an important and independent risk factor. And of course, sleep is an issue for every person with a small baby. But it reinforces the necessity, particularly in people with mood disorders, to make sure that we're accounting for and treating sleep disorders or insomnia or any other structural factors that are making sleep even worse for people with mood disorders in this period. So from those two studies, what are the differences and what can we conclude, and how do we think about the next studies that we do? The very first study I showed you, where we had that allopregnanolone in the second trimester predicting the development of major depressive episode, that study was done with a clinician-diagnosed disorder. So it was a conversation with a psychiatrist using a structured interview to determine whether the person met criteria for an episode of major depression. The second study, we didn't have that in the postpartum. We just had scales. We did it at the beginning to determine their history of a mood disorder, but we just based everything on scales. That has pros and cons. The pros, obviously, it's a lot easier to do the study that way, but we aren't picking up an episode of major depression. We're picking up elevated symptoms, which may not be specific to a particular disorder. The first study that we didn't have any measurement of anxiety at all. So it was based purely on depression. In the second study, we saw that we did have a measurement of anxiety, and that seemed to parallel what was going on with mood. We had the same kinds of results, whether we looked at a mood scale or an anxiety scale. The other thing to remember is that in the second study, the women remained really well, even though half of them had a prior history of a mood disorder. Only 4% of them were actually above the cutoff on the EPDS for likely postpartum depression. And we had that much lower rate of medication use. So those are the things to think about in those two different studies. And the other thing to think about is, what are those missing links in the chain from the second trimester to 6 weeks postpartum? What is going on? What is that low allopregnanolone in the second trimester setting into motion that then results in symptoms at 6 weeks postpartum? And I won't have time today to go into all of the possible things that could be in the data that we're gathering there, but I'll give you a few hints. Before I do that, though, I'm going to show you the results of a third study that is currently in process. These are unpublished data, and we're just currently finishing up a manuscript on them. And in this, I'm going to focus particularly on that metabolic pathway. So everything I've showed you so far, we just measured allopregnanolone levels and looked at their relationship to mood or anxiety symptoms, either in the future or at the same time. And one of the big questions we had after doing that was, what are those links in the chain, and how does this relate to everything else rather than just allopregnanolone in isolation? So we decided to really try to look at the whole metabolic pathway. So going from progesterone down to allopregnanolone, it's a two-step process. We go through 5-alpha dehydroprogesterone. Remember, that's the precursor that I said is actually excitatory. It has the opposite effect of allo. And there are two key enzymes, 5-alpha reductase and 3-alpha HSD, that govern those links in the chain. And then progesterone similarly goes down this pathway toward pregnanolone, same, very similar enzyme here, same enzyme here, again, going through an intermediary. And then once you get down to allopregnanolone and pregnanolone, there are stereoisomers that it's a conformational change. It can go back and forth between pregnanolone and epipregnanolone, and between allopregnanolone and isoallopregnanolone. So if we try to consider some of these other actors in that metabolic pathway, maybe what we're seeing is defect in some of these enzymes that's not making the pathway go through. Maybe there's a genetic issue. The genetic issue I showed you before is a genetic difference in the SNP that's on this enzyme, 5-alpha reductase, that does that first step in that pathway. So the first thing we did was we looked at the ratio of progesterone to those metabolites in the second trimester to see if there was a difference for those who went on to develop postpartum depression. And again, remember that these were people healthy in pregnancy, does not have a relationship of allopregnanolone to mood symptoms at that time. They didn't have mood symptoms at that time. But what is that relationship like in those who went on to develop postpartum depression? And this is the progesterone to allopregnanolone ratio. This one is the progesterone to isoallopregnanolone ratio. So I'll just show you that slide again. Remember, it's this conformational change between allo and its isomer. And so what we discovered was that in the darker bar here is the people who did go on to develop postpartum depression. The lighter bar is the people who did not. The red star is just showing you this is a statistically significant difference. And we can see that the people who went on, people who went on to develop postpartum depression had a higher ratio of progesterone to the metabolites at the second trimester. So what that means essentially is that they had artificially lower levels of the metabolites. So something was getting stuck at progesterone and not getting through to the metabolites in the second trimester for people who went on to develop postpartum depression. Another thing that we've looked at, again, looking along the pathway, is what I'm calling pure anxiety. So everything I showed you before, the first study we did was people with a prior history of a mood disorder. We didn't measure whether or not they had anxiety. They probably did. We didn't measure it. The second study, we were specific in including people with mood or anxiety disorders, and we measured both mood and anxiety. This third study is pure anxiety. So it's people who do not have concurrent depression. We screened out people who didn't have concurrent depression. Some of these people had a prior history of depression in the past, but nobody had depression during the study. Again, same issue we had before. It's an older, largely white, highly educated population. And what did we find? Well, here we found we did a mediation model where we looked at this pathway from progesterone to that intermediary 5-alpha DHP, going all the way to allopregnanolone. Did any of these relationships change depending on whether you were in the anxiety group or the non-anxiety group? And we defined that by, we had people enroll based on their score on an anxiety scale or meeting criteria on the SCID for an anxiety disorder. But not everybody who enrolled at that way stayed that way. People's symptoms changed across time. So we used a data-driven approach to determine who was in the anxiety group and who was in the non-anxiety group across the course of the study. And what we found was that the relationship between progesterone and allopregnanolone differed depending on which anxiety group you were in. And we found a strong positive relationship between progesterone and allopregnanolone for people who were in the anxiety group, and we found no relationship for people who weren't. So in other words, for the people in, this is in the 3rd trimester, so people in the anxiety group, as progesterone was getting higher in the 3rd trimester, allopregnanolone was also getting higher, staying higher. But people who were not anxious didn't have that relationship. So that may indicate that in the non-anxious people, we're seeing what I showed you back at the beginning, where allo is supposed to go up across pregnancy and then come down toward the end. So the non-anxious group, it's coming down, and the anxious group, it's not coming down. It's not doing what it's supposed to. And as I said, these are unpublished data. We're still playing with exactly how we're going to present them. But another thing we've been looking at is that ratio of allopregnanolone to progesterone across pregnancy and postpartum. And what we're seeing is this is not a statistically significant difference, but it's sort of a dramatic effect and of the ratio of allopregnanolone to progesterone, and that change as you transition into the postpartum. So the blue line is the people who are doing what you're supposed to do in healthy postpartum. You stay up, you maybe are coming down a little bit from the 2nd trimester to the 3rd trimester as we get into that very end of the pregnancy. And then in the immediate postpartum, your allopregnanolone level should go way down, right? As your receptors are being upregulated. And so the non-anxiety group is doing that. The anxiety group is not doing that. So the people who are staying anxious into the postpartum are keeping their allopregnanolone levels up. So again, maybe that's so the postpartum perhaps is more a picture like we get with PMDD, where the higher allopregnanolone levels are associated with irritability, mood, or anxiety symptoms. So the other pieces that we need to look at, that we are looking at, but that I don't have data to show you today, is that GABA receptor subunit composition, right? So a lot of this may have to do with the interaction between the neuroactive steroids and the receptor. So this is kind of my little theoretical model of what I think could be going on, right? The people who are having that allopregnanolone low early in pregnancy, those people who are more prone to postpartum depression. Well, maybe what's happening as they go through pregnancy, the people who are healthy are seeing their allopregnanolone levels rise. People who are anxious are not seeing them rise as much as they should. And that is in pregnancy. And then that's leading to, in the healthy people, what's supposed to happen is the increased expression of the delta subunit, which leads to tonic inhibition, decreased expression of that gamma subunit, which is what allo binds to, and that's not happening for some reason in the anxious people. This was my theoretical idea for how it worked across pregnancy, but I just showed you a graph where what actually seemed to happen is that the anxious people, their allo stayed high in the postpartum. So I'm going to have to sort of think and refine this idea as we get more data from the postpartum. Another thing that's going to be really important to consider is how these systems interact with other systems that are also having effects on mood and anxiety. I mentioned inflammation and I mentioned the HPA axis. This again is just a theoretical model going into a study I did to look at how all of these things interact together, with the anxious people having lower allopregnanolone and therefore higher inflammation, and that relating again to altered HPA axis activity. I do have some data on inflammation, and we're looking now that I can talk about separately. We're looking now to see what that relationship is with allopregnanolone. I don't know those data yet. So what does this all mean in terms of the usefulness of neuroactive steroids in treating? And when you think about it, a lot of it seems counterintuitive, right? I'm saying allopregnanolone may stay higher for people who have symptoms in the postpartum, and yet we use allopregnanolone to treat postpartum depression. So how does that make sense? Allopregnanolone to treat postpartum depression, of course, is brexanolone, which is the first drug ever approved for postpartum depression in the United States by the FDA. And it was an exciting development for, I'd say, two main reasons. One, what we were talking about just before the talk, the fact that this is a drug that is based on years of basic science research into how neuroactive steroids work. And it's actually been developed into a drug on the basis of that research, rather than we accidentally discover a drug that happens to work and work backward from that, which is the way it usually works in psychiatry. But the other reason that it's a really exciting development is that it's a drug approved for postpartum depression for the first time. And that's an acknowledgement that postpartum depression may be something distinct from depression at other times. I very strongly believe that. I think it's a biologically different mechanism, but the way we define it, certainly in terms of our diagnostic scales, in terms of the DSM, it's not given its own separate category. And so this is a mark that maybe that's something we need to be considering. How does brexanolone work? It is essentially a synthetic version of allopregnanolone, so it works just the way allopregnanolone does. It's an injection, an IV infusion, and it attaches to that GABA A receptor where it works as a positive allosteric modulator. It's an infusion that's given over 60 hours. So there's a 12-hour dose titration given across the first half of the first day. Then they're at the maintenance dose for 36 hours, and then they have a 12-hour taper down. As I mentioned, it's an IV infusion. It can be given only in the hospital. And these are what the data show. And I like to show these data because there were a number of different studies done. This is the integrated study of everything all together. And what you can see is that there's a dramatic effect on mood and anxiety symptoms in the first 72 hours while they're getting that infusion. Blue being brexanolone, green being the placebo. So we see a dramatic effect for brexanolone. We're seeing a pretty dramatic effect for the placebo as well, right? And these are statistically significant differences. There's no question that brexanolone has a bigger effect, but it's a very dramatic placebo effect. And a lot of people have speculated, well, you're taking women, you're making somebody else take care of the baby, you're putting them into the hospital for 3 days and letting them sleep. To what extent is the brexanolone effect have to do with that? And to what extent does it have to do with the drug? And I think that there's lots of longer term questions and issues that arise because of that. You know, clearly you can't solve postpartum depression just by getting sleep, but if the act of going into the hospital to get treatment for this may change the family dynamic around the postpartum depression, it's making the family say, wow, this is something serious, this is something dramatic. Not only do we need to get the woman treatment, but maybe we need to change the family structure, we need to change the kinds of help or social support she has at home, and that may be what helps to maintain the effect over time. I think there's a lot we don't know yet at this time. There are some adverse effects, but they're really pretty mild. We were doing brexanolone treatments at Johns Hopkins, and we rarely saw somebody who was particularly sedated. It does have a REMS warning. There's a special prescription monitoring program for it because of some events of sedation or loss of consciousness in the initial trials. I've not seen that clinically when we've done it, and I don't think any of the sites that have been doing clinically have reported that. So it's really pretty well tolerated. People are a little sleepy, they nap, but they don't lose consciousness. There's also now an oral version that is being submitted now to the FDA for approval, zuranolone, and it has also been found to be effective against placebo. It's a 2-week oral version. You take it for 2 weeks and then you stop. And it is found to be effective out to 45 days is what the data are now showing. Again, there's a pretty strong placebo effect. And that can't be the effect of putting the woman in the hospital and having her get some sleep, because this is an oral drug given at home. So I think those data are still in progress. This has not been approved by the FDA yet, but we expect it to be probably within the next year or so. There are other neuroactive steroids that have also been tried out. Brexanolone isn't the only one. There's one called ganaxolone that was done in a phase 2 study, and it was just a 6-hour IV infusion. So you wouldn't have to stay in the hospital, and then it was followed by a daily oral, but that did not have significant results at 28 days, and it's never been published or pursued as far as I can tell. Ganaxolone has been used in the postmenopausal population with some effect. And there's another one called sopranolone that is being used for PMDD. This is the opposite kind of drug. So those previous drugs were allosteric modulators of the GABA A receptor. Sopranolone is an antagonist, and it is blocking the effects of the neuroactive steroids. And remember, in PMDD, we had that rising ALA, which was associated with irritability. So the idea in PMDD is if we block that, we can reduce symptoms. And this was an initial trial, but that looks very promising for the possibility that sopranolone may be useful for this population. So what do we conclude from all of this? I think that there's still a lot of research that needs to be done, but basically we can conclude that there's substantial evidence that neuroactive steroids have a role, have some kind of dysregulation in the pathophysiology of reproductive psychiatric disorders, but that the relationship between them and the symptoms may differ according to where you are in the menstrual cycle, according to where you are in pregnancy and postpartum, so that the relationship during pregnancy may be different from the relationship postpartum, and that may have to do with changes in the receptor conformation. It's really important how we define reproductive illness. We can't say that depression during pregnancy is the same as depression postpartum. We can't say that depression, we need to be really careful about the timing of when symptoms arise if we want to get to the answer of what this relationship is and whether it's causal. And in terms of treatment, it seems like there are promising avenues for treatment, but it's still pretty early days, and we don't yet have a lot of long-term data for either brexanolone or, of course, zuranolone, which is new. So there's a lot yet to be done, but I think it's a really promising avenue to explore. We're trying to tackle the question of the neurosteroid synthesis, the metabolic pathway, by looking at all of those molecules as well as the enzymes, and most importantly, by expanding into other racial and ethnic groups. It's one thing to prove that this works in white women in Baltimore. We have no idea if that means it works across races and ethnicities. So we actually have a large grant application pending to look at it in a much more diverse set of people. This is just a big thank you and shout out to all of the people who have helped me do my research. This was my lab at Johns Hopkins, some of whom have come with me to Cornell and some of whom have not, and all the people who have been staff and fellows and mentors in this work acknowledge the funding that we've had up here. And I think that is it, and I would love to hear your questions and comments.
Thank you very much. I'm going to open for people if they have any questions, but I have a lot of questions. I don't know. I think one of the challenges is how we diagnose in psychiatry. Like sometimes we clump depression and anxiety into as one thing, but there are different things. There's symptoms of possibly different things, and how to tease out which one is due to the postpartum or which ones are due to other things. It's sometimes hard. I think that's one of the challenges of finding the exact pathophysiology of the disease.
Yeah, I think that's exactly right. And I think, the NIH has gone more toward the idea of identifying symptom clusters rather than diagnoses. Exactly. Like, we don't care what you call it, we care what the symptom is that arises. Is it anhedonia? Is it irritability? And I actually think that research-wise, I certainly support that, because what is impairing to people is what types of symptoms they are experiencing rather than what we call it. So, to diagnose depression, you can have 5 out of 9 symptoms, but 2 different people who are called depression can have 2 different, really different clusters of symptoms. And I can't believe that the pathways that affect anhedonia are the same pathways that affect irritability, restlessness, anxiety. Yeah. And so I really do think that isolating symptom clusters is the way to go, and it might help us map onto what's actually happening in the brain. I've been really focused on studying anxiety alone, because anxiety, I think, gets the short shrift. People study depression all the time in the perinatal period, and anxiety is more common. And I find it's more impairing. When I treat a pregnant woman who has depression, I can usually convince her to take medications because she's feeling really terrible. And I discuss the medications with her. She understands, she agrees to take them. If I treat a woman who's suffering from really impairing anxiety, she's almost never willing to take medications because she's anxious. She's worried about what the medications will do to the baby. And even if I explain that they are compatible with pregnancy and she can use them, she can't get out of her head to do that. So I think it can be more impairing, and it's harder to treat for that reason. So we may need different kinds of treatments or different approaches. And if we don't tease out what's different about those kinds of symptoms than the more sort of anhedonic, listless, depressive symptoms, we're not going to be able to help these people.
And what's your theory about, we know that allopregnanolone increases during pregnancy. So you have a downregulation of the delta subunits of the GABA-A receptor, which are mostly extrasynaptic and due to the tonic inhibition. So we disinhibit the tonic inhibition. When after the delivery, you have a drastic, abrupt decrease in allopregnanolone, and you gradually recover the upregulate down the GABA-A receptors.
Mm-hmm.
Do you think that's similar to it's intuitive to think about it in terms of anxiety, like mostly anxiety symptoms, because if you disinhibit the tonic inhibition, then you probably have. But I think that the challenge is to translate this to like those things, those differences into what happens at the systems levels, like in the circuits and which regions of the brain. Do you have any ideas if there's any difference between what's happening with this in anxiety and depression, if it's different or if it's more or less the same?
Yeah, I think that's a great question. And I do think being able to look at the conformation of the subunits is key. And we can actually isolate GABA receptor subunits in peripheral blood. But the data, I've tried to do that in the lab, and the data we got was not very good. So we need to keep working on that, or see it through neuroimaging. But the thing is, I suspect that the mechanism is very different in pure anhedonic depression and in pure anxiety. The problem in the postpartum is that for most women, what we have is something that's a mix. Postpartum depression is an entity with a lot of anxiety and irritability in it. So it isn't the same as an anhedonic major depression. You know, if you look at that paper that came out a few years ago that took the Putnam paper that took women with postpartum depression from across the world, did a data-driven approach to identify different clinical phenotypes of postpartum depression. They came up with 5 different phenotypes. 3 of the 5 phenotypes had the word anxiety in them, right? So anxiety is such a key component of postpartum depression, you know, and I think it may be that what we have is a spectrum of postpartum mental illness, that all of which has anxiety in it, and some people also have depressive symptoms. So I think figuring that out in the postpartum isn't necessarily going to help us figure out what is the case for depression or anxiety outside of this period. I think it may be distinct.
Do you know if there's any work on postpartum psychosis with allopregnanolone?
With allopregnanolone, I don't think there has been yet, but that would be a really interesting place to look. The problem with that, of course, is that postpartum psychosis is such a rare illness.
Yeah,
that getting enough people, you know, I think it would be really interesting to look at. The original trials for brexanolone excluded people with postpartum depression, with bipolar disorder. And so anybody with postpartum psychosis, most of those people are on the bipolar spectrum. So nothing has been tried. I think it would be a really interesting thing to do. Yeah.
So I think Morena has.
Yes. Hi, Lauren.
Hi.
It is a great pleasure and a privilege to be here, listening to you talk about this topic that I really love. I read once about a possible relationship between PMDD symptoms and perinatal anxiety and depression symptoms, what would be called a reproductive pattern, something like that. And I would like to know if there is a relationship between PMDD symptoms and depressive and anxious symptoms in the perinatal period, whether women who have PMDD are more likely to have depression or anxiety during pregnancy or the postpartum period.
Yeah, and so what you're talking about is the concept of, you know, reproductive depression, which that term, I believe, was coined by my colleague Jennifer Payne back in a 2009 paper. And the idea being that if you are somebody who has PMDD, or, you know, there aren't very many women with PMDD, there are a lot of women who have a premenstrual exacerbation of another mood disorder. PMS, right? Those women are at more risk in the peripartum period. They're also at more risk in the perimenopause transition. So we know that there is a subset of women who are vulnerable to hormonal fluctuations. What we don't know is, we don't think it's the actual levels of hormones that are causing the problem. We think it's change and fluctuation. So in PMDD, there are some people who speculate that it's the steepness of the rise or the steepness of the fall of allo in the luteal phase that is related to those symptoms, that may have something to do with it, but it's more that those individual women have a vulnerability to change. And we see that in, the study that was done back in 2000, I think Block is the first author, where they took women and they shut down their menstrual cycles, then gave them back estrogen and progesterone to mimic postpartum depression. And everybody with a prior history became ill, and nobody with a prior history of PPD became ill. So that really shows you that the levels of hormones were not any different. They had exactly the same. It's that some women have that vulnerability, and we have not identified what that vulnerability is. I think there may be genetic differences, there may be epigenetic differences, there may be people who have differences in their immune system. So we haven't succeeded in making those connections yet. But yes, for sure, they're more vulnerable.
Mm-hmm. Thank you.
Yeah.
What about stress-related disorders like post-traumatic stress disorders and stuff like that? I know that the GABA-A delta receptor hypofunction has been implicated in a number of disorders, like seizure disorders and stress-related disorders. Is there anything being done on the use of those neurosteroids into people?
Yeah, it's interesting. I don't think it's been tried clinically, but it's a really good thing to do, because there is a huge amount of data now on neuroactive steroid dysfunction in PTSD. My colleague Graziano Pinna, who's at the University of Illinois in Chicago, he's our collaborator on this neuroactive steroid work. And his lab has done a lot of stuff on PTSD and trauma and stress related disorders, and have found significant dysfunction. So somebody should definitely try out brexanolone for PTSD. Yeah, and I think the other interesting question then is, what about PTSD or other kinds of trauma and stress related disorders that come about as a result of birth trauma? Right, we have a significant number of women, particularly in this country, where obstetric care is so terrible. They have PTSD as a result of a traumatic birth experience, and how's that related?
I think we have the same issue here in Brazil, especially Rio de Janeiro, which have a lot of communities with that are controlled by drug dealers and traffic. So I think I think patients wouldn't be in short supply here. I think
they're not in short supply in New York either. So
yes. So I think Marina, she had her hand raised again. Oh, okay. Does anyone have any other questions, or do you have any? So sorry to, if you have to go, just let me know. But I still have a lot of.
I'm good. I'm good so far.
Okay. Have you? Does anyone over there do any? There's another type of they're like steroid type molecules, like oxysterols, that are NMDA agonists or allosteric modulators of NMDA receptors, that have been used to treat, not to treat, but have been implicated into some symptoms related to schizophrenia. So I was watching, I don't remember exactly what was the study, but Steve Paul, he was talking about 24S hydroxycholesterol, which is produced in the brain, and it used to be thought of as a molecule to remove cholesterol from the brain, but now they found out that it has activity into NMDA receptors. So in symptoms where you implicated with NMDA hyperfunction, which are some symptoms of schizophrenia, they found out that this molecule, this oxysterol, it reverses the treatment effects of ketamine. And sometimes in rodents, it reduces, they have some models of schizophrenia with PCP-induced deficits in social interaction, and this molecule actually reverses this PCP-induced deficits. Is anyone over there do you know anyone who's been working with that? Or
not in the perinatal period, certainly. Obviously there are a lot of people studying how and why ketamine works or doesn't work. And, I think it would actually be a really interesting thing to look at in the perinatal period, because of course there are lots of cases of, there are some cases of postpartum psychosis that actually turn out to be NMDA receptor encephalitis cases that the presentation is very, very similar. So I think that I don't know of anybody working on it, but it's a really cool area.
Okay.
Yeah.
Just a curiosity.
There probably is. I just don't know the person.
Okay.
Yeah.
All right. It was great to hear about your work over there. Let us know if you have any results from the studies that you're doing. I'm sure I'll be looking into any publications that might come out recently. And you're also invited to come presently in person, maybe next year. We can.
Yeah, I would love to do that.
Reproductive psychiatry events. You can suggest some names, and we can do something like an event here in Rio. I think that would be a good thing to stimulate people to study this here. And
I think that would be.
We don't have the resources that you have in terms of basic biology, bench neuroscience, but perhaps the clinical studies that
you have the patients,
possible,
right?
are more feasible here. But thank you for your time. It was a great talk, and I look forward to hearing from you again. And let me know if you need anything from us, or if you can do something as well.
All right, thank you. It was a great pleasure, and I'm going to say that I look forward to meeting you in Brazil someday, because I would love to do that.
All right.
All right.
Have a good day. Bye-bye. Thank you.
Bye-bye.